All right, welcome to this high-yield explainer. Today we're taking a fast-paced, highly focused blitz straight through the salivary glands. I am so excited to guide you through this because we're going to break down the whole shebang. Everything from your basic, everyday benign cysts right up to life-altering conditions and into those complex, high-stakes surgical complications that can literally change the shape of a patient's face. We have got a lot of absolutely crucial ground to cover, so let's jump right in.
Okay, so here is our roadmap for today. We're hitting 1. Cysts and infections, 2. Salivary gland stones, 3. The gland size rule, 4. Major parotid tumors, and finally, 5. Surgery and complications.
Starting off with Section 1, cysts and infections. Basically, the plumbing problems of the salivary system.
Now, think about this for a second. What actually gets your saliva going? You know, for a lot of us, just the thought of a decadent sweet, like a rich pastry or some sugar-laden treat, is enough to trigger an immediate biological response. Your salivary glands just start pumping out saliva right away. But what happens when that constant, heavy production of fluid suddenly has nowhere to go? Well, that is exactly when the trouble starts. And this brings us to a massively tested scenario, the ranula. Fun fact, the name literally refers to a frog's belly. A simple ranula is basically a mucus extravasation cyst of the sublingual gland. It sits right there in the floor of the mouth, has this slightly bluish tinge to it, and because it's just filled with clear fluid, it is brilliantly transilluminant. Now, compare that to a plunging ranula. That's a mucus retention cyst that actually pushes right through the floor of the mouth, creating this dumbbell-shaped swelling that you can actually feel way down in the neck. So the absolute crucial takeaway here is management. You must never, ever just incise and drain a ranula. If you just poke a hole in it, it's going to recur almost every time. Instead, you've got to use marsupialization, meaning you suture the edges open, or you completely excise the cyst along with the sublingual gland itself. And of course, you have to be incredibly careful to avoid the lingual nerve while you're in there.
Let's rapid fire through some other high-yield benign quirks you absolutely must have on your radar. First up, the Staphny bone cyst. Honestly, this is just ectopic salivary tissue resting in the mandible. Don't confuse it with a cyst related to an unerupted tooth, okay? Next, what about a parotid abscess? This is critical, so listen closely. Fluctuation is a late sign. The parotid fascia is incredibly tight, so if you're waiting for the abscess to get soft and fluctuant, you've waited entirely too long. You need to act early. Moving right along, we have HIV parotitis. This creates these multiple bilateral cysts that look exactly like Swiss cheese on imaging. And finally, Kuttner's tumor. Now, despite the terrifying name, it's actually not a tumor at all. It's just a chronic sclerosing inflammation of the submandibular gland.
But let's say you do have to surgically drain a parotid abscess. You are entering incredibly dangerous territory here. And this perfectly illustrates Hilton's method. Because the facial nerve runs right smack through the parotid gland, you simply cannot open your instruments blindly. You must always insert your forceps and open them strictly parallel to the facial nerve. If you open them perpendicularly, you risk snapping a major facial nerve branch, which leaves the patient with permanent, devastating paralysis. No way do you want that on your hands.
Moving on to Section 2, salivary gland stones, or sialithiasis. So, mealtime syndrome is a term that perfectly describes what the patient is actually experiencing. Imagine sitting down to your absolute favorite meal. Your glands start pumping saliva, but a tiny stone is completely blocking the duct. The gland violently swells up against that roadblock, causing a really painful neck mass right after you eat. Over the next couple of hours, the saliva slowly seeps past the stone, the swelling goes down, only for the exact same agonizing process to repeat at the very next meal.
But why does this happen? Well, the submandibular glands are the prime targets for these stones for a couple of reasons. First off, their saliva is much thicker and more viscous. Second, their drainage duct actually has to push that saliva upwards. It's literally fighting gravity. Because of this, they form these stubborn calcium phosphate stones. In fact, 80% of these are radiopaque, meaning they'll light up beautifully for you on imaging. The gold standard for diagnosis here is a non-contrast CT scan. If the stone is small, say under 4 millimeters, we can go in endoscopically with a little Dormia basket and just fish it out. But if it's larger, we have to surgically incise the duct. And keep in mind that incision absolutely must be longitudinal to prevent nasty strictures from forming when it eventually heals.
All right, Section 3, the gland size rule. Let's talk about salivary malignancies.
The demographics of these glands are quite literally a cheat code for understanding salivary gland pathology. Look at this massive shift on the table. The large parotid gland is overwhelmingly benign. 90% of the time, a mass in the parotid is nothing to panic over. But as we move down in size to the submandibular gland, boom, it becomes a 50-50 coin toss. Down to the smaller sublingual gland, it flips to 80% malignant. And when we finally look at the hundreds of tiny minor salivary glands scattered all across your hard palate, a whopping 90% of tumors there are malignant.
So I really want you to mentally screenshot this golden rule right now. The larger the salivary gland, the higher the percentage of benign tumors. The smaller the gland, the higher the percentage of malignant tumors. It is the most logical foundation you can hold on to before we dive into the really specific tumor names coming up next.
Which brings us perfectly to Section 4, Major Parotid Tumors, the heavy hitters.
First, let's contrast the two benign giants. The pleomorphic adenoma is the most common tumor overall. It's closely tied to a PLAG1 gene mutation, usually presents as this slow-growing, painless mass in females, and crucially, its borders have these insidious, microscopic finger-like projections. If a surgeon tries to just pop the tumor out by simple enucleation, those little fingers get left behind, causing a massive recurrence rate. That is exactly why the minimum acceptable surgery is a superficial paratectomy. Now be warned, if a pleomorphic adenoma suddenly starts growing rapidly, becomes painful, or paralyzes the facial nerve, it has undergone a deadly malignant conversion. On the flip side, presenting completely differently, we have the Werthin tumor. This is the second most common benign tumor, but its demographic is the complete opposite. It heavily favors older males who smoke. Fascinatingly, it involves the tail of the parotid and is the most common tumor to present bilaterally, hitting both sides of the face in about 10% of cases.
Now for the bad news, the malignancies. The most common malignant parotid tumor is mucoepidermoid carcinoma, which is heavily linked to radiation exposure and the CRTC1 MAML2 gene fusion. But the tumor you really need to fear is the adenoid cystic carcinoma. This one is the second most common, but it presents with intense, agonizing pain. And you might be wondering, why does it hurt so much? Because of a terrifying feature called perineural invasion. These tumor cells actively hunt down and invade the local nerve sheaths. Pathologically, it creates these cystic spaces that look, once again, exactly like Swiss cheese under the microscope.
And let's see how all this builds into a brilliant clinical pearl. You see, the parotid gland actually has a superficial lobe and a deep lobe. When a patient comes in with a lump on the side of their face that's lifting their earlobe, well, that's just a superficial lobe talking. But how do you know if the hidden deep lobe is enlarged? You have to look inside. Always examine the oral cavity. If you see the tonsillar fossa being physically pushed medially towards the center of the throat, that signifies the deep lobe of the parotid gland is dangerously enlarged. A superficial swelling only ever tells half the story. Section 5. Surgery and Complications. Welcome to the surgeon's minefield.
Let's blast through these high-yield surgical nerve injuries because they are so heavily tested. If a surgeon accidentally cuts the marginal mandibular nerve, the patient wakes up with a drooping angle of the mouth, literally a crooked face when they try to speak. If the greater auricular nerve gets severed, a male patient might complain months later of complete numbness on their cheek and jawline while they're shaving their beard. If the main facial nerve trunk has to be sacrificed to remove a radical cancer, it requires bridging that gap with a cable graft most optimally harvested all the way from the sural nerve in the leg. And if we move further down to the submandibular gland, the major structures at risk there are the lingual and hypoglossal nerves.
So, to desperately avoid cutting the facial nerve during a parotidectomy, surgeons rely on a very specific, meticulously mapped safety guide. The most famous landmark is the tragal pointer, also known as Conley's pointer. The main nerve trunk consistently lies just 1 single centimeter inferior and deep to this cartilage. Surgeons also palpate the styloid process, they locate the posterior belly of the digastric muscle, or, in really difficult reoperations, they perform retrograde dissection. That's where they find a tiny nerve branch at the edge of the face and meticulously trace it backward until they find the main trunk.
But here's the crazy part. Even if the surgeon does everything absolutely perfectly, a bizarre complication called Frey syndrome can still occur. Imagine this. After recovering from a parodontictomy, a patient sits down, smells some delicious food, begins to chew, and the side of their cheek just starts profusely sweating. What just happened? Well, it's called gustatory sweating. When the parotid gland was removed, the auriculotemporal nerve, which used to tell the gland to produce saliva, was left severed in the surgical bed. Over time, those postganglionic parasympathetic fibers regrew, but without a gland to connect to anymore, they incorrectly attached themselves to the sweat glands in the overlying skin. So now the brain says, make saliva, but the face produces sweat instead. Just wild.
To definitively confirm this in the clinic, we use a true diagnostic marvel, the starch iodine test. The steps here are fascinating. First, you paint the patient's cheek with iodine and let it dry completely. Then you lightly dust the area with starch powder. Next, you simply hand the patient a piece of food they love. As they chew and those rogue nerve fibers start firing, the sweat mixes the starch and the iodine together, turning the sweat visibly purple right before your very eyes.
So the ultimate question has to be, how can surgeons prevent this bizarre sweating cheek syndrome from happening in the first place? Well, if the nerve regrows because there's empty space between the surgical bed and the skin, we just need to put up a roadblock. Surgeons can wrap the nerve stump by pulling up a flap of the sternocleidomastoid or the digastric muscle. This creates a thick, physical barrier that stops those rogue nerve fibers from ever reaching the skin.
Let's wrap up the last of these parotid complications. First off, performing an extracapsular dissection rather than a full superficial parotidectomy drastically lowers the risk of Frey syndrome for benign tumors. Now, if a patient already has Frey syndrome, we can manage it somewhat simply with an antiperspirant stick or targeted Botox injections, but the definitive surgical cure is a tympanic neurectomy to just cut the nerve entirely. Finally, what about fistulas? If saliva is just leaking through the gland tissue, it's a low-output fistula that usually heals entirely on its own. But if a major duct is leaking, that is a high-output fistula. It's a true surgical nightmare requiring a really complex ligation known as the Newman and Seabrooks procedure.
And that officially concludes our high-yield blitz. I want you to think about the incredible journey we've just taken. From the simple, everyday act of craving a sweet treat and producing saliva, we have descended into this intricate, high-stakes biological web. We've seen how a tiny calcium stone can cause agonizing mealtime swelling, how the sheer size of a gland dictates its deadly potential, and how a surgeon has to navigate millimeters away from permanent facial paralysis just to remove a tumor. So, the next time your mouth waters over a great meal, I want to leave you with this provocative thought. How well do you truly know the fragile, hidden biology operating just beneath your own skin? Thank you so much for joining me on this explainer, and as always, keep learning.